task meeting. Before we start the meeting, I have a statement to read out concerning the last meeting. At the last meeting, the Health Overview and Scrutiny Committee, the question of attendance of Woking Medical Centre at a Health Overview and Scrutiny Committee meeting was raised. I would like to clarify that in October, a request for information was sent to the primary care networks as to the challenges and successes that their surgeries were currently experiencing. Representatives from some of the PCNs attended the committee's November meeting to provide this information. No formal invitation was issued specifically to Woking Medical Centre. End of statement. Thank you. Right, let's start to go through the agenda. Sorry, I'm looking at the wrong agenda. Right, have we any apologies, Madeleine? We have a show.
Yes, Rebecca Margett, Alistair Neal, and Michelle Shepherd-Bay, and Alison Swaddle and Morag Morvan are here as substitutes.
Thank you, Madeleine. Has anybody got any questions on the previous minute meetings? Anything to raise on that, or we'll accept those? Oh yeah. So there is one tiny little change that we need to make. The title of Andrew Statham, Director of Strategy, RBH, should be Andrew Statham, Director of Strategy, RBH, NHS Trust. So that will be corrected on the minutes, but it's a minor change. Next point is declarations of interest. Does anybody have any? Public question time. Were there any public questions? Member question time? No. So we move on to the meat of this meeting, and I must say beforehand that unfortunately Health Watch will not be here tonight. They've got sickness, so they will not be able to present. So we will not have that item. However, I believe the pharmaceutical team are here. I think it was David and Karen, is it? So I would like to hand over to David, if that's okay. Thank you very much. Welcome to our lovely WBC HOS committee, and it's good to meet you and see you. And would you like to start off? I think in the briefing notes I've seen, you haven't given a lot of information. So I guess you're going to give us that information now. And normally we would try and do some Q&A session at the end. Is that okay with you?
Yes, absolutely.
Super. So I'll hand over to David and Karen. Thank you.
Thank you. I just would like to introduce myself first. I'm David Dean. I'm Chief Officer of Community Pharmacy Thames Valley. So we're the statutory body, the LPC, that looks after, represents and supports community pharmacy across the whole of Berkshire, Oxfordshire and Buckinghamshire. And Karen's asked me to attend today just to give some background and context to around the landscape in terms of community pharmacy in the Wokingham Borough at the moment. There has been some recent concerns with closures of pharmacies and permanently and short term that there was an issue with community pharmacy at the moment across the borough. I'm here with some better news actually now. So we recently lost all the Lloyd's pharmacies within Sainsbury's, and that's now been and gone and happened. And the pharmacies that have been left behind are coping well, I think, with the uplift in patient numbers that they've seen on the back of that. They had particularly low numbers of patients in those supermarket pharmacies anyway, I may add, but they did have extended hours, which is something we may need to revisit with the ICS in the future. But you now have 19 pharmacies across the borough. Lloyd's as a pharmacy brand has all but disappeared now from our high streets. The few that were in Wokingham have all been sold to existing pharmacies or pharmacists and have now all taken place. And I'd like to add they've been sold to pharmacy contractors that are known to us and have got a good reputation and are keen to support their local community and are keen to offer a much, much better service than was previously offered. Recent challenges in pharmacy has been around workforce. That has improved substantially, where the availability of replacement pharmacists and locums has improved. And in the next couple of weeks, we'll get a new intake of newly qualified pharmacists entering the job market, and hopefully that will plug the couple of gaps that we've got at the moment. The only remaining issues really are around supply chain, which is a national issue. There's ongoing issues with getting hold of certain medications, but we're in negotiations, or the national body is, with the government to try to alleviate that. And on the whole, I think that pharmacy is in a much, much better place, looking forward to providing much, much better healthcare for their community, and making plans now for the coming winter and the upcoming campaigns for flu vaccination and potentially COVID vaccination for the autumn. And that was all I had to say, Karen. I'm happy to take any questions and anything else that you may want to add, Karen.
Brilliant. Thanks, David, for that context, and thank you, Chair. So for those who haven't met, I'm Karen Buckley, consultant in public health here at Wokingham. And the remit from a public health perspective and our kind of responsibility is to look at need and assess need. And so we do that from the pharmaceutical needs assessment that which we do every 3 years. And should there be any changes, such as David's has alluded to with the closure of Lloyd's at Sainsbury's, then we would review that data and look at the need and see if that has any implications on our residents. So we did do that recently, and it didn't have any implications on our residents. And it's reassuring to have kind of the update from David around that provision going forward. So any such change, we would always go back to the data and look at that. It is summarised in the paper. I'm happy to kind of give a bit more detail on that if that's helpful.
I mean, if you can add any further detail, then please do so.
Yeah, so I guess the key thing is the pharmaceutical needs assessment, we do that every 3 years. We follow national guidance in terms of the criteria that we set. It is a kind of robust methodology that we apply. So we look at the data, the demographics of our population. We look at the future projections of our population. We survey and speak to our patients and the public around their use and expectations of pharmacy services and what they expect from pharmacies. We also speak to our pharmacy providers and contractors to understand their capacity to fulfil current and future need. And then we have that kind of consultation period. In terms of assessing need, there's a lot of criteria, but the kind of 3 key criteria that we look at is accessibility, which is the one that our residents locally report as being the most important to them. And so this is determined in terms of national criteria, which we apply locally, which is this 1 mile radius to your home, to a pharmacy. And that approximates to a 20-minute walk, or in those more rural areas of our borough, that's where it's that 20-minute drive. And so there will be proportions in our population who don't quite meet, but there is 20 pharmacies now within Wokingham, and 22 pharmacies located within a mile of the Wokingham's border. So there is enough pharmacy provision in terms of accessibility. We then look at the provision of those pharmacies. So David touched on some of the services they provide, the essential services, as well as NHS services and enhanced services. And we also look at the hours, so core Monday to Friday opening hours, as well as evening and weekends. And so there is a collective view. So any one pharmacy closure or change, we would look at it collectively in terms of that provision for our residents. So at the moment, there is good coverage in terms of that assessment. And, you know, should there be any change, we obviously need to continue to review that. But it was reassuring to hear that news from David. Happy, as with David, to take any questions.
Thank you very much, both of you. I'll start with Beth, please.
Thank you very much. I'm the member for Southlake in Woodley, and I have to say I think I must be in a different borough. We have 2 pharmacies in Woodley, about 40,000 residents, and I have gone to an online pharmacy because I am so fed up for many years of standing for an hour in a queue waiting for something that they haven't sorted out yet. And I think many of the residents, certainly from the Woodley Facebook pages that I look at, are saying the same thing. The pharmacist in one of them persuaded me a little while ago to bring my business back locally, which I would like to do. They had 2 scripts, both of them they failed to make. And so I've gone back to my online pharmacy. That isn't a good picture, and that certainly isn't what I'm hearing from my residents. So I don't quite know how you justify it. The other thing that I'm concerned about is Boots announcing that they are closing some of their pharmacies. We have one Boots pharmacy and one Day Lewis pharmacy in the town. Day Lewis are already complaining that they're handling all the scripts from Winnish practices and are overloaded, and certainly residents are complaining. I don't know if Alison's picked this up as well, about having long waits in the Day Lewis pharmacy to collect their medicines. But the picture that you have painted is not the picture that's evident to me or my residents.
David, if you want to come in.
Yes, of course. For first, the Boots question. Yes, 300 Boots, not necessarily all pharmacies, may be closed in the coming year. They have said that they will pick pharmacies or stores that are very, very close to existing ones, so that shouldn't affect Woodley. I take on board your view around the 2 pharmacies you have in Woodley being particularly busy, and that is true. We haven't had anything brought to us directly, but I'm happy to look into it. But I'm always an advocate of supporting your local community pharmacy as opposed to taking it online, because if you do have an issue, the first place you want to go to is to have a face-to-face with your pharmacist. But I do take on board, I am hearing what you're saying. We haven't had that feedback from Day Lewis or Boots about being overly busy or hearing of queues up to an hour, but I'll happily look into that for you and see what we can do to support and help.
I think it was Morag next, I think. No, it wasn't. Sorry, Tony.
Yes, I was going to ask about the Boots. But another thing that came up, I was talking to a local pharmacist, and I think it's to do with the supply chain issues that David was talking about, that he was saying that when things are in short supply, they're working on a sort of supply and demand basis, and the price goes up, and he's not getting paid the amount that he's having to pay to supply the drugs. And is that something that we're aware of and that we can deal with or assist with?
My thoughts on that would be to contact your local MP and let them know that your local pharmacy is having issues. It has been raised nationally by the government, and you are indeed correct. There are certain medications where the pharmacist will get reimbursed maybe £3, but costs him 20 to actually pay for it from the wholesaler. It's a known issue, and one that if it continues could cause the demise of a couple of pharmacies going forward, because financially they just can't operate on that particular model. And it's something we're lobbying for nationally to try to resolve.
Thank you.
Phil next, please.
Hi, I guess this is to David. I've got 2 questions, actually, very different, if you wouldn't mind. The first one is related to what Tony said. The shortage of drugs, are they drugs that are manufactured in the UK or are they abroad? And are they drugs with a short shelf life, or are they different? And the reason that I asked that is because I was involved in a business only as a supplier that used to do parallel imports of drugs from, say, for example, Greece and Spain for various inhalers and that sort of stuff. Mm-hmm. Are those routes still available to us in order to alleviate some of these shortages, or are they not the sort of drugs that we would have problems with?
It's a real mixture of medications. Some of it will be around purely they get paid more to supply those medications in other countries as opposed to the UK, because the government quite rightly will have a price that it will only pay a certain amount for, so those drugs end up somewhere else. There's a little bit around manufacturer being short of certain ingredients, so the number of boxes made has been limited because demand increasing in China and India, where a lot of pharmaceuticals are originally sourced. And the supply chain, the way it works at the moment, is broken in terms of, sourcing particular medications for pharmacists can take a whole day a week to try and find the right medication for their patients. And it's something we're actively trying to encourage the government to fix. I'm not going to mention the Brexit word, but we did have a buffer of medication built up, and that disappeared during the pandemic. So when you talk about light and often and just in time delivery, it's got to a point now with medication it is really, really tight. And with the recent Strep A outbreak before Christmas, the government actually stepped in and banned the export of medication from the UK to other countries to help alleviate supply chain over here. And more of that will be needed in the future, I think.
Okay, I mean, I'm happy from my side to lobby our MPs that serve this area on that particular subject. It's disappointing that perhaps some of the drugs that we are finding shortages of are manufactured here. I won't mention any manufacturers' names, but in some ways it doesn't surprise me. I shall take that away and do what I can with my colleagues. The second question is sort of related to the other question you've asked, which is to do with staffing, and very much part of the sorting out the problems with GPs' availability of appointments and all that. Has been pushing some people with relatively simple health conditions to consult at their local pharmacies. Is this affecting the staff availability for the dispensing of drugs, or is it affected by the shortage of staff, in which case it's not so effective in helping the GP's waiting lists?
A very good question. And it is, again, a mixture of responses, because it's a very good thing that we're helping our colleagues in practice with their waiting lists and the ability for patients that really do need an appointment to get one. And those patients that are being referred to pharmacists for consultation is a great thing for patients to get to see a healthcare professional much more quickly. And to be honest, with the funding model, the way it's been built, it's good up to a point, but then the pot of money has run out. So the more that you get paid for seeing referred patients from a GP means that you get paid less for dispensing items. So there's a limited amount of money, and the more that you do, the less that you get paid in the end. But I would say is that we've got an extra £645 million worth of investment coming in from the government to see more patients for very minor conditions, like infected insect bites, sore throats, impetigo. And they're the sort of conditions that pharmacists are well trained to deal with and to prescribe medication for, which will happen hopefully towards the end of the year. And that can only alleviate, again, waiting lists at GPs. And I think long term, that would be the vision of the government, to make sure that there's a choice for patients to either go and see a GP or another healthcare professional, whether it's a community pharmacist or some other healthcare professional that you can get to quite easily.
So just to finish off, if you don't mind, Chair, I want to clarify your answer on that last point. Does that mean you're confident with the new staffing that you believe is in the pipeline that you won't be then increasing your own queues in order to do these consultations?
There are severe workforce pressures, whether you're in pharmacy or cafes or restaurants, unfortunately, because that's the world we're in. There is a shortage of people everywhere, and pharmacies are doing their best to attract the right the people and train them appropriately. And, there's no instant fix, and the big labour workforce plan that the government launched on Monday will go a little way to try to rectify that, but there'll be pinch points in healthcare as professionals leave pharmacy to go become GPs or work in hospitals. Then that'll leave a vacuum behind for pharmacies. But long term, we're doing what we can at schools of pharmacy, and indeed when children leave schools to choose their careers, we're trying to build upon the fact that pharmacy and healthcare in general is a fantastic career to choose, and hopefully we can fill the gaps in the future. But there'll always be pressure on workforce, especially with the pressures that every employer is under at the moment to try to find the right people for the right jobs.
Thank you.
Alison next, I think. Was it? No? Shahid?
Thank you, Chair. A couple of points. First one, I just want to echo what Beth said earlier on, just sharing the similar experiences, personal and my family as well. Long waiting time, prescriptions not being ready on time or only limited, not the full supply. And as a result, we actually have to move, go to another pharmacy outside Woodley, and where we are getting a much better service. So I think a number of other people have mentioned similar things. So I just want to echo what Beth said earlier on. So there is an issue in Woodley. It needs to be addressed, but this is not what the picture which was portrayed earlier on. Also, regarding this, actually the prices as well, that's another thing which has been noticed, because it's to do with the supply chain as well. There was some, only a couple of months ago, I'll give you an example, eye drops, which is costing about £4. Recently, we had to pay £16 for the same item, 4 times as much. It seems to be a ridiculous amount you have to pay just because of, it's a simple eye drop. It's not, but the price is absolutely ridiculous. So I don't know whether this is a supply change issue or is something else. I'm not really sure. Perhaps you guys are better informed. And just the last one. So I mentioned earlier on that some of the enhanced services will be taken up by the pharmacists, right? I mean, I speak obviously I've got 3 pharmacists in the family as well. I see them as professionals, and I just want to echo David that actually it is a great profession, and they're very happy in that role. But I think what additional services are being talked about, I know it was discussed in the last meeting as well, but it wasn't, and also the timelines when those services, enhanced one, will be added to their inbox or say. So the reason I'm saying that is so make sure that the GPs are actually freed up to do the work which they do, because there's a pressure a lot at the moment getting appointments as well.
Yes, thank you for that, and I take on board your comments around Woodley as well, and I will take that further. Supply chain is a complete. It is baffling to me as well. I don't understand some of the price rises that come through either. But perhaps we do need to be looking at some of the big pharma companies for their answers in terms of the price increases that have been passed on lately. With regard to enhanced services, there is a fantastic service at the moment for GP referrals to pharmacy. I think there's over 2,000 a month, nowhere near enough that patients get sent to pharmacies for minor illnesses, for consultations. That will increase steadily over the coming months as practices gain confidence in what pharmacies can do, and pharmacies upskill their teams in how to take on and manage those referrals. The extra ones I was talking about should come online in the autumn, hopefully. It all depends on negotiation. We've got a great blood pressure case finding service for hypertension that's running really well at the moment across the whole borough, and particularly successful in Wokingham, actually, funny enough. We're also piloting an addition to our new medicine service for antidepressants in the Frimley patch, so that will come through to Wokingham as well. And we've got an early cancer diagnosis pilot in Oxfordshire, which should go national in February and March. So there's lots going on. It's just obviously there's only so many hours in a day, and with the training and the upskilling and the electronic processes that have to be built, we can only do so much at a time. But there is a lot happening, and it's just making sure that we get pharmacies the appropriate funding to do it safely, and being able to recruit extra people if they need them to deliver those services.
Firstly, David and Karen, many, many thanks for coming here. I know we ask really, really tough questions, and that's our job. And, those questions aren't directed at you guys personally. I know there's significant challenges out there. I do have some further questions, which I would say, follow on from several points that have been raised by several of the committee members. The first point, actually referring back to our last month's meeting, where Sarah Webster, who's the exec director for Berkshire West, said that this could be achieved including greater use of other appropriate settings such as community pharmacy. So the ICB is expecting more delivery from pharmacy. And, you know, if we expect to give, I would say, non-critical things, let's call them non-critical things, to pharmacists or initial assessments or something like that to pharmacists, they will obviously need to be there in the first place. They will need to be staffed and everything else. And I'll come on to some points around individual pharmacies rather. So this is the aspect from the ICB, and this is what is anticipated as, you know, an increasing load on pharmacy. First question, is there a kind of CQC inspection routine for pharmacies?
We don't get inspected by CQC, we get inspected by the GPHC, the General Pharmaceutical Council. All the visits are available in the public domain. Very similar to Ofsted, you get your reach standards, not meet standards, not reached. So they get visited once every 2 to 3 years. In addition to that, every year, every pharmacy is expected to fill in a sort of a self-regulation questionnaire, which is then double-checked, and other questionnaires and visits indeed may take place by the NHS regional team to ensure that there's governance and clinical protocols in place for the safety of patients and delivery and dispensing of medication.
Another question on supply chain. My wife requires HRT, and she had difficulty in obtaining her medication for, I would say, 18 months or 2 years, and she was going to virtually every pharmacist in Woking Borough. I was going to almost every pharmacist in Woking Borough, and sometimes we were coming away with a partial delivery of a script or no delivery of a script, and pharmacists regularly saying, you know, everywhere is out of this or that or the other HRT, which had a significant effect on her health. And, you know, it would have had the same effect on many, many women across this borough. And I think it's absolutely shocking that we're in the 21st century and we can't get relatively straightforward mechanisms like these patches that she has. I mean, these are not, you can store these almost anywhere. They don't need to be stored in a fridge or anything. You know, when you make them, you can make a huge batch of them. Why did they disappear for nearly 18 months, 2 years? And do we have any confidence at all in the supply chain of HRT? I know the government gave the role of a HRT czar to some person because that was on the news. So hundreds of thousands of women are asking the same question. Where is my HRT? What's the answer to that?
I'm not a politician. I don't mean to answer like a politician, but I certainly wouldn't put my house on the fact of trying to find medication, that you expect to be supplied freely. Supply chain is broken, full stop. I can't guarantee any, it's like a lottery. A pharmacy can ring in the morning at 10 o'clock, get told there's nothing. 10:30, another one down the road finds out, you can have 2 boxes. That's all we've got. Next pharmacy, nothing. It's horrendous.
I mean, because this supply chain issue looks like it's going to be a very long-term issue, I think we will need to invite you back again on a regular basis so that we can have an update from your perspective as the expert on the ground, if you like, as to how pharmacies are coping with a broken supply chain, using your words, broken supply chain. I wanted to go into the specifics of the pharmacy as I said, I've been to just about every pharmacy there is on many occasions trying to chase down all sorts of medication. I'll start with Woking Medical Centre. When this was originally started, there was kind of one pharmacist and 2 or 3 helpers. I went there last, probably 6 weeks ago, for a partial script for my wife. And there was, I would say, 12 people working in there. So clearly there's not a staffing problem. I believe there were 2 pharmacists working and, 10 assistants or whatever they're called. I don't know their official titles. But there was a huge number of people actually dispensing and scripts. I was shocked, to be honest, to see such a level of staffing. But one question that arises from that, the actual pharmacy site is a very small site. It's probably 3 or 4 meters wide by 4 or 5 meters deep. So it's, I don't know, 16, 20 square meters, and you've got 12 staff, and it was absolutely frenetic in there. There was a huge number of people waiting for scripts, people waiting out of the door for scripts. Even though the pharmacists and their assistants were working incredibly hard, the level of activity was enormous. I couldn't believe it. Things, they have an automated machine from the roof, and things were flying everywhere. It was like something out of Harry Potter. It was amazing. So I'd have to question whether that pharmacy has the capacity to deliver the number of scripts it's expecting to be delivered. That's my question for that. Boots used to be have 2 or 3 pharmacists and many assistants, and used to have a huge central rotunda with thousands of drugs on it. And now you're lucky if you find 1 assistant or 1 pharmacist working there. Boots looks almost like the Mary Celeste. I've seen a massive degradation of staffing and drug supply from Boots. It is, when I look at it, it looks as though it's just about to close. It looks as though they're going to turn the lights off and shut it down. So I'm very unhappy about that. And that's probably one reason why Woking Medical Centre is absolutely crazy. Now, Morrison's Woos Hill, the staff that work extremely hard, I can see they're all stressed. I regularly use that because that's a default automated system from our GP surgery. And I have a number of questions. You mentioned the blood pressure service. Morrison's have a sign which says, "We no longer deliver blood pressure monitoring services." That sign is up, as far as I'm aware, today. It was a week ago or 2 weeks ago, and it has been for weeks or months. So I don't think they are involved in the blood pressure service, which I believe you said was across Woking.
They're not signed up, looking at my list here, yeah.
Okay. The size of the pharmacy, I mean, it's a few square meters of space with an absolutely tiny consulting room. Obviously, if we are expecting that pharmacy to take the load, which it is due at the moment from Sainsbury's and other areas, what happens when there is a major immunization program? What happens? The consulting room, as far as I can see, is so tiny and is now, every time you ask for any drugs, one of the assistants goes in and out and in and out of that tiny consulting room. So clearly that consulting room is not being used for consulting. And I think it has a sign on it saying, there's no consulting or something like that. So I would really have to question the size of that facility, because it's absolutely tiny. And I normally see 30 to 45 minute queues there. And the number of scripts they deliver is enormous. and I think it's completely overloaded. So those are the specifics on the pharmacies. Final question. A lot of people, have said to me they're very unhappy at Sainsbury's closing. Every time I went to Sainsbury's, there are always people at the pharmacy or asking questions of the pharmacist or requesting scripts. Was anybody in the NHS, or you, David, or anybody from WBC, was anybody involved in Lloyd Pharmacy and Sainsbury's action plans to close that pharmacy? Was any points raised or questions raised to Lloyd's or Sainsbury's or anybody about the removal of that facility?
That would have been a national conversation, but if a business decides to close down its business, there's really not much that we can do about it. Obviously, there was a pharmacy contract there, but to open a replacement pharmacy would have meant it'd have to be within the Sainsbury, and Sainsbury's didn't want a pharmacy within it, and you'd have to open up to 100 hours a week, because that's how it got its contract in the first place. And 100 hours a week pharmacy is very, very difficult to run at a profit, which obviously you need to do to make it viable. I'm really sorry to hear about your experiences at those three pharmacies. I mean, the size of a pharmacy is beyond our control, but a lot of the things you're saying point to the fact that these pharmacies need some support. Financially, community pharmacies have been starved of revenue, had the same revenue for the past 9 years. So when you look at rents, they've gone up and up and up, but you're not getting any more money from the funding from the government, not any more money for salaries. So the minimum wage has gone up from £6 something to over £10. So you're looking at 60% increase in that salary for that person, but no increase whatsoever in funding for pharmacy. So all those things add up, and it means teams are smaller and more stressed, and they can't afford to extend and refurbish and to develop their businesses as much as they'd like. So it's really, really difficult for pharmacy at the moment. But I will say that most pharmacies remained open all the time throughout the pandemic. We have taken part in a massive immunisation programme. The flu vaccination programme has increased 4 times in the last 4 years in pharmacy, and we expect that to continue to increase over the coming months. And to be honest, pharmacy needs that revenue for those services to keep going. If it didn't get it, then they would not survive. So it's a bit of a vicious circle, unfortunately. They need to be busy to survive, but if they're busy, then they're maybe not as efficient as they could be and should be. But you're quite right to bring up those points. And, I'd encourage anyone that has a bad experience within a pharmacy to follow their complaints procedure, which initially is to raise it with the superintendent of the pharmacy. So if it's a chain, there'll be a superintendent based at the head office. If it's a small pharmacy, they'll have somebody within that pharmacy or locally down the road. And then there are steps beyond that, which you can raise your concerns with the ICS, who will work with the NHS regional team. Going back to the Lloyd Sainsbury's question, locally, the NHS regional team worked with the regional teams at Lloyd's to ensure that the phasing out of the pharmacies would have minimal disruption locally. Unfortunately, Lloyd's decided then to bring forward all the closing dates by 3 months and sort of stopped doing their pharmacy contract stuff many weeks before they should have done. But again, I need to highlight the fact that local pharmacies actually cope really, really well at short notice. And indeed, I'm hearing that a lot of the pharmacies that were close to Sainsbury's are now taking on extra staff to help cope with the increased demand, because they're getting that reassurance of that increased workload, which is increased revenue, increased finance to help them survive and to, make their businesses more financially viable. And anyone who knows a pharmacist, and I know the gentleman earlier on said, 3 pharmacists in the family, they work really, really hard, long hours, and they are absolutely 100% committed to their local community and their patients. and they'll move heaven and earth to deliver what they need to deliver for their patients. And that, some of that is doing stuff they shouldn't do, like, making deliveries after they've closed to patients that need it. And, perhaps, working many, many hours, asking the staff to work many, many hours that go, uncompensated, unfortunately, just for the benefit of those patients locally. But do bear with us. But there's no excuse for bad service and no excuse for shoddy service. And, we'll do what we can to work with those pharmacies to improve things in the future.
Sorry, I wasn't in any way criticising any of the staff.
No, I know you weren't. I just wanted to highlight.
I've seen the staff doing above and beyond and working tremendously hard. I think it's the workload that is the primary issue. I have one further question. I looked at your P&A report and I looked at the diagram showing the coverage, and obviously in the centre there was Sainsbury's, Lloyd's Pharmacy, and if you move to the left, there is obviously Arborfield and Barkham being the closest proximity to Sainsbury's. So that's gone. So Winnersh doesn't have that provision now. But Arborfield and Barkham, I'm trying to anticipate a question from Rebecca, who's unfortunately not here. But Arborfield and Barkham is a huge area of development of houses, and there is no shops, there's no nothing there. And, that number of people living in those locations really have to go out of their way to Wokingham or Reading or wherever to get to anywhere near a pharmacy. And I think part of your description was within a mile, there's no way they've got a pharmacy within a mile or within 5 miles, I would have thought. So my question is about Arborfield and Barkham. Is there ever going to be any provision for pharmaceutical services in Arborfield and Barkham?
I think this is one for you, Karen.
Well, yeah, so I can talk about, obviously, the closure. As in the supplementary statement in the report that went, so as you rightly say, 10,000 residents do not fit within that 1 mile radius in terms of our national criteria, but all residents fit within a 20-minute drive. So not ideal, we recognise that, but there is provision and capacity across in terms of national guidance that does meet the criteria for residents. In terms of your second point around planning, in terms of new residential building and that taking into account, that does need to be taken into account, and that would be ICB, NHS working with LPC and David. I assume I'll let David fill on that one.
Yeah, absolutely. Obviously, if there's a lot of house building, I know the area very, very well, and it's unrecognisable from where it was even 5-6 years ago. And, if demand reaches a level where a pharmacy and other healthcare services are needed, that'll form part of the P&A. I'm sure a keen, enthusiastic pharmacist would bite our hand off for the opportunity to open a pharmacy in that area if an opportunity arose. So that is part of the P&A. It looks at future developments. But as it stands, when the P&A was written, a need wasn't identified. But that can change and will change, I'm sure.
Thank you for that confirmation. And I think, whether Rebecca's here or not, we will continue to follow this story of Arborfield and Barkham, which the residents are really annoyed with delivery or lack of delivery of shops and services, including pharmacy. I'd like to hand over to Phil now.
Thanks, David. Just building on really your last answer. I would say that twice within the last 6 to 9 months, councillors from within Wokingham have contacted me to say that they have been spoken to by one of their new residents that have moved in from far and wide into the new estates, asking how easy would it be for them locally to be able to open an independent pharmacy? Is there space for them? So my question is there space for them? Where do they go to discover that? And where do I direct them to? Firstly. Secondly, do you have the pathways set up to easily bring those people that want to take the leap of opening their own business in pharmacy? Do you have the pathways available for them to be able to do that?
the pathways are there for anyone to open a pharmacy where a need is identified in the P&A. That's the first thing. If I wanted to open a pharmacy tomorrow, that's what I'd look at first, is that document to find out where an opportunity arose. But as it currently stands, in the current P&A, so if an application was made, it wouldn't succeed because has been identified there is no need at the moment. But that again may change.
Is that even after the withdrawal of the Lloyd's services and things like that? Were you saying that we had oversupply previously?
Yes.
I find that astonishing. I know that that's not enough question, but I find it astonishing that you say that. So
I can come in if you want. So yeah, it's referring to that national criteria and how we set that out. So the provisions, we had 22 pharmacies, we now have 21. You look at it collectively, and there is that provision in terms of that capacity and being able to offer it. I'll just find the statistic so I'm saying the right statistic. It went from, so you look at per population per pharmacy, it went from 1.2 pharmacy per population head, and it increased. So the capacity and the supply is still there. It meets. Potentially will come a tipping point at some point in the future, should pharmacies close, should people not utilise their community pharmacies, as David Dean has alluded to. But that pharmaceutical needs assessment, that regular review of need and demand and future demand, is reviewed every 3 years.
Ingrid, do you want to add something?
Summarise, I guess, so I feel I absolutely hear your point. Like, it is not ideal, but the way in which the P&A works is the standardised kind of way that we are not able to locally adjust. And there are two measures of within the P&A. One is the number of pharmacies per head of population, as Karen's just outlined, and then once you've got that, and that's within an acceptable, in inverted commas, acceptable for national standards, you then look at this measure of accessibility. So it's not like you can't, the structure and the way in which we have to do a P&A doesn't allow us to go, in this one ward of Wokingham, is there a pharmacy? It doesn't allow us to do that. So we are very tied by the formula by which we have to deliver that piece of work on a 3-yearly basis. And there will, as both David and Karen said, there will be a tipping point, either on that number of pharmacies per head or on the accessibility issue. But that has not, and whilst things are not great, and I absolutely have heard all of that sat here, but we aren't at that tipping point as defined by central government at the moment, unfortunately. So it's difficult to call additional local pharmacies into action, given that we can't evidence that within this P&A document at this point in time.
Thank you very much, Ingrid. Shahid, do you have a further question?
Sorry, thank you. Just actually building on that, I just find that we, as maybe the public facing as councillors, on one side we're hearing that we are following the guidelines, and based on the guidelines there is initial provision of the service. On the other side, we're hearing from the public that the service is not good enough, right? So there's a clear sort of distinction between here. At the end, the people in the shop and say, we don't have enough service. I mean, we highlighted a number of issues I highlighted before. To tell the residents that we are, the following and the guidelines are being followed as per the national, you can just imagine that is not really a good enough answer from their point of view. They are not getting a basic service. They need medication. They can't get it on time, or it's not sufficient. They have to travel 20 minutes, it was mentioned, of drive. I mean, that could take me to Slough or even further, right, to go to that in some cases.
Well, that doesn't fit with the climate emergency at all. Yeah. If everybody is expected to drive for 20 minutes to get one tiny little package of drugs, that's not going to fulfill our requirements for 2030 or 2050.
The point I'm making is this: fundamentally something is not right here. One side is this message: we got enough provision, we are following the national guidelines, right? On this side, there is not enough provision. So I think there's something missing here. I can't pinpoint what it is, but I think we all feel, I can just, looking at everyone, that this is not really an acceptable. Secondly, when is that, is it PNN, is the right wording? When is going to be looked again? You said at 3 years. When is that 3-year time period is going to end and that is going to be relooked?
So if I can just come up, look, I absolutely hear the frustration. I share the frustration with you. I think we all do. So it isn't that we're sitting here saying that this is a simple thing and you're telling us that residents are telling you something different. We hear it. We know it. We hear it from residents too. I think the difficulty is, and why it feels like there's such a big gap in the middle, is that this is a hugely complex problem. This isn't simply about a number of pharmacies. If it was, we could solve it by opening more pharmacies. But if we opened more pharmacies and supply chain problems remained and medicines weren't on the shelf and we couldn't get the pharmacists in, we would still have a problem with residents' experience of pharmacy. So there isn't a simple solution, and I think that's why it's so difficult to move it forward. And I think that moving, I think that as one of the first things that we can do, sort of sensibly, I suspect, is, as David has pointed out, is that those that you have raised here in the room as individual pharmacies, where clearly service is not of the quality that we would hope it might be, that his organisation will be able to support them to try and increase that service. But in terms of those, and then Phil has also mentioned work on your side, perhaps have been able to lobby some of your MPs around some of those broader national issues around supply chain and pharmacy tariffs that are meaning that running pharmacies is in many cases a loss-making activity. So I think there are so many different and complex things at play that makes it difficult for any single organisation to address those issues. In terms of our PNA, it's about 18 months before we have to do the next one. So we're about halfway through that cycle. And that sits under the Wellbeing Board. It's a statutory document of the Wellbeing Board, but we can of course bring it here too.
Yeah, I can see, sorry, just to I can see, I just spotted actually it's reviewed in 2025. So I assume 18 months it will be reviewed, and then by the things are implemented, assuming there is actually a need has come up, by the time it's implemented, it could be maybe 2.5 years down the line when service might be improved. Is that a fair judgment?
So again, part of the issue around this whole system is that the PNA does not directly create action. So the PNA is a statement of need, and that's the only bit that the local authority is responsible for. And so we make the statement of need. What subsequently happens from that statement of need isn't up to us. We have no control over how that is interpreted by people who might want to set up a pharmacy, or how that's used by commissioners to commission more pharmacies. So there is a disconnect between our work as a local authority and the work of those that then have the power, let's say, or are in control of being able to provide better and more services within pharmacies. So those two things added to that complexity. Pharmacies are independent businesses, so it's very difficult to say, please come and put a pharmacy here if people don't want to. So there's so many levels of difficulty, but obviously our bit, the PNA, will be out in 2025. The statement of need will then be available for others to read, look at and make use of as they see fit, but it's hard for us to influence that.
Phil's got one more question, and then Alison.
Sorry, thank you, Ingrid, but I'm afraid this is for David again. The one thing that my experience shows me recently, I don't mind declaring, I was given a drug which I've been told is virtually for life, which is a statin. Probably half the room or half the people we know are on them. But what that has identified for me, firstly, that I was really frustrated that I was given 28 days at a time, which meant I was constantly getting repeat prescriptions, which drives me nuts, mostly because I remember to ask for them when I've got 2 left. So are there any technological things that are missing to enable pharmacies to predict the levels of drugs they will need, which may indeed help with the supply issue?
Yes. So the two things, it's very complex again. Nothing's easy, is it? There is an electronic repeat dispensing program that practices should be implementing. So you don't have to request for your own script. It will be generated automatically. And most practices should be using that system today. So that means when you collect July's script, you'll actually put August's script in the cloud for the pharmacy to call off a couple of weeks before it's due, to assemble it in their own time, so they can do it, when it's quiet, when they've got the medication ready, and then you just come in at the usual time to collect it. And we choose 28 days because that minimises the impact on supply chain, because if everybody switched to 2-month or 3-month prescriptions tomorrow, there wouldn't be enough stock in the country to fulfil all those scripts. So they keep it to 28 days on the safe side. And what I will say, and Ingrid's quite right, there's a reason why Boots are closing 300 pharmacies. There's a reason why Lloyd's closed 250 pharmacies in Sainsbury's. There's a reason why the whole of Lloyd's have sold 1,700 pharmacies. It's because it's really damn hard to make money in pharmacy at the moment. So even if you gave permission for a pharmacy to open tomorrow in Arborfield, you probably wouldn't get one for 3 years because nobody wants to do it because it wouldn't make any money. So we need to make sure that the pharmacies that are here today are financially viable, become prosperous, become really great for their community. And we work really closely with the ICB and with the NHS team to make sure that we protect and grow our existing pharmacy population. Because if we don't, we'll lose even more. And, changing the P&A to attract more doesn't really help those that are here today.
Okay, well then it seems to me that one of the first things that you seem to be partially addressing is efficiency, which helps to drive down cost. I consider myself, others may disagree, a relatively intelligent, well-organised person, and yet I haven't managed to see anywhere that is the case, that those drugs are available to me in that way. So when we spoke to GPs about availability of appointments, way to access appointments, and all the rest of it, one of the things that they said that they needed assistance with was publicity. Now, is there perhaps information which is not being given to patients that are being prescribed, that we can look at that and make that message clearer or more obvious? Because if we can save phone calls to GPs, if we can save wasted visits to pharmacies to pick up stuff which isn't there, then that's all helping with the efficiency. It's just a question, it's pretty basic, but is there something that can be done about communication?
Well, and don't forget, not everybody is digital literate as well. So we need to make sure that the 80% of the population that is digitally literate does what they can and uses all the things at their disposal, whether it's apps or electronic prescriptions or the patient NHS access app, whatever it's called, to allow time then to be given to those people that can't access apps, can't even leave their house to collect their medication. And that's what we need to be better at doing. Sorry, Ingrid, you had your hand up.
I was just saying, we can take that, David. That's a good point, Phil, and we can take that away and see whether there's anything we can do locally in terms of messaging out to residents so that they can help get the most efficient use of their local pharmacy. And it might be that we can do a bit of a campaign around that in a comm sense to help get the message. I was also going to just suggest, Chair, that perhaps when this comes back as another issue, as another review point in a future HOSC, is just that we ought to have the ICB here at the same time. Because
that's a good idea as well.
Given that the P&A is used as a document to support the Commissioner and the ICB is the Commissioner, they really ought to be here to explain their decisions around how they commission pharmacies.
Alison, final question.
It's only a small point, but having read the P&A, and you've got your circles to show 1 mile from a pharmacy, that has to take account of the River Thames. When you're showing pharmacy at Tesco's Henley as serving all residents in Remenham, when they'd have to go up to Henley, past the other pharmacy to get to that one, it's not within a mile. Showing a pharmacy in Caversham as for people in Whitegate, that's not within a mile. I know it looks nice to do a complete circle, but let's be realistic. We've got physical geographical features. That means it's not within a mile.
They are taken into account when we look at maps. We look at motorways running through communities and rivers and all sorts of things. But you're quite right to raise it.
I actually, no more questions. Right. So I wanted to talk to Ingrid actually, because we're all focusing on the P&A because that's the next step in the road. But what you're saying is the P&A is just that step and there's other steps after that. So I was going to ask if Ingrid could present to us the steps that are required to get a new pharmacy, whether it's goes to the ICB and the ICB goes to whoever, and whatever the chain of command is. Could we get a presentation, a PowerPoint or something like that of what that chain of command is, and then we can lobby our MP or we can take further actions. So that is a request for a further session. But you kind of partially answered the question by saying, the ICB should be here at the next pharmacist meeting, and I think that's a good point. Beth, final question.
Not a question, Chairman, but something to add on to what you've said. David said earlier on that the supply chain was broken. It seems quite clear to me that the pharmacy chain is also broken because it isn't working. And I think most of us have said something about it tonight. So that clearly is broken as the supply chain, and two broken things fall down. And we can't afford for it to fall down because that's people's lives.
Right, we're going to close this section of the meeting. I mean, David, thanks very, very much. Aaron, thank you very, very much. Ingrid, thanks a lot, as always, for your support. I know these are really difficult and challenging times and situations, and we sincerely hope that you will come back and present to us again, and we thank you very much for all the work you do with pharmacies, and as you said, David, trying to keep the pharmacies that are here viable and continuing in business. This is really an essential service for our residents, and our residents need to give you a big slap on the back. Thank you very much.
You're welcome, anytime. Thank you very much. Thank you for your support, everyone.
So the next item is, I believe, Sorry, KPIs. So adult social care. Lorna and Lisa are going to present here. So it's all yours, ladies. Thank you.
Lovely. Thank you, Chair. And thanks, everybody, for the opportunity to come and meet you and talk to you and hopefully answer any questions you have. Assuming you've all seen the report that's been provided, it's got a lot of detail in there, so we weren't planning to regurgitate that up front. Just wanted to kind of run through a couple of key things with you, really. First of all, I'm sure every time adult social care come and talk to you, they talk about how challenging it is to work in the current environment. That's certainly been very true of the last year, against a kind of historical context of adult social care not being funded at the levels it needs to be. We're in the situation where we've got a cost of living crisis, huge inflation over the last year, and that's put a lot of funding pressure on a system that's already very stretched. So the teams are working, they're very much up against it. Off the back of that, we've had a number of providers, so commissioned services operating in the borough, who, the same as the national picture, have been experiencing financial difficulty and sometimes some viability issues. That has implications for business continuity, and it does impact on the choices that are available around quality care for us and other people to purchase. So against that background, we feel very positive about the performance that's been achieved in the last year. To summarise, 71% of targets have been achieved across the whole year, and the other 29% are slightly off target. But when you look at the year as a whole, there's no areas that have been significantly below target, which is really positive. We're aware of some slowing down in that if you look at Q4 in isolation. And that's important for us to be aware of and pick up on going forwards. Overall, really strong performance though, and when you benchmark it regionally and nationally, it performs very well. And I'm just going to let Lisa tell you a little bit about some of the other highlights.
Yeah, I'm sure we'll be able to talk about some of the lows as we have some questioning. So we did just want to take the opportunity really to mention a couple of the highs that we've experienced this year. And notably, we want to draw your attention to our project at Hatch Farm, which was our accommodation project, where we won a national award for the best social housing initiative. That for us was quite something. We worked in partnership. Yes, indeed. We went out with Hugh Edwards for the evening, who presented our award, as we do. But it was a very special award. We worked together very closely with our partners in housing and in commissioning. Optilis, our local authority traded company, we all pulled together, and we've got 35 individuals, vulnerable individuals with special housing needs that are loving their new accommodation. So we just thought it was very, very helpful to talk about something that's been so important to us. We've got a really challenging year ahead. We know this. For the first time this year, we could be, and quite possibly we will be experiencing a CQC inspection. So that's quite large for adult social care, and it's something we are planning for the eventuality of now. We're very clear of where we as a local authority don't do quite as well. And we've got a quite ambitious transformation plan in place at the moment. Notably, we are looking at our adult social care pathway. We know that the way it currently runs means that there are some bottlenecks. We know that there are some delays for our customers, and we are doing a lot of work at the moment to try and redesign that. We've ambitiously set the target of September, so we have been working over the last few months quite hard to try and resolve some of those issues. And part of that, as well as working very, very closely with our partners in the voluntary sector, and our aim is to work as closely as possible with them so that customers are receiving the right support from the right places. So there's going to be a lot happening. I'm sure you've seen the report. I'm sure you've got lots of questions. So we're open to answering them as best we can.
Thank you for that highlight. Congratulations. I think the team, all the hard work which has been put in over the years. As we know, this does not happen overnight, right? And it's a long, hard struggle which was going on. And actually, I was a chair of one of the housing committees, and I've seen that space. It's a great place, and I actually visited that when it was open as well. So thank you for that. One read, you guys, social work assessment allocation to commence within 28 days, right? So and just expand on that, why that is the case, and what is the repercussion of that as well not happening. And second question, it was mentioned earlier on that some of the providers of the service are actually probably closing down their business because it's financially not viable. What type of provision were there, which are we talking about, which is disappearing or the supply is limited, and how is that going to impact our residents and obviously those customers who are in need?
I'll answer the first part, Shahid. So in terms of the 28-day assessment, that is not a national performance target. So it's a target we've set for ourselves and Wokingham, which is quite ambitious. I think across the region, I think we've got a stat here which shows that 26% of people are waiting longer than 6 months for an allocation. So in terms of the last year, we have met our target for the 28-day assessment, aside from the last quarter. Now, this isn't entirely unexpected because it measures exactly the same as we performed last year with the winter dip. Notoriously, it becomes a very, very busy time of year. Our stats show that we've had more referrals in. We're definitely seeing more complexity, and I think we've seen that since COVID, and that has not slowed down. So we are seeing more pressure on our waiting list. The complexity of the work that we're doing, the longer we're having to stay involved, the more OTs and physios, etc., we're needed. So we're hoping that the next quarter we will see a rise again, and that's the aim. And it would be silly of me not to mention that, we were talking about with the pharmacy services earlier, staffing has been problematic for us. No doubt about it. We have experienced vacancies. We are working really hard in adult social care. We have a workforce strategy now that we're working very hard on. We are trying to grow our own. We're offering apprenticeships in social work and occupational therapy, which haven't historically been available, so that's good news. And we have reevaluated our entire recruitment campaigns to do a lot of work about how we can attract people into an area which is really, really tough at the moment. We've had people leave to after having degrees in social work and occupational therapy, leaving to go to supermarkets, etc. So the pressure on adult social care at the moment is really, really tough. But as I say, I think we've done well throughout the year. We're benching very, very well in terms of how we are doing in the region, and we hope the next quarter will rise again.
And if I just talk to your second question a bit, so we've spent a lot of time and energy the last few years, very much since the COVID pandemic started, building really strong relationships with our providers in the borough. And the pandemic was a double-edged sword in that way, I think, because obviously it put a huge strain on the provider market, but it gave us an opportunity to change the nature of our relationship with them, and for them to very much see us as part of one team in terms of, delivering good quality, safe and effective care. So I think we have a good starting point in that our relationship with providers means they talk to us early when they're having issues. So I don't think we're ever really in a position where we get the curveball of an unexpected provider failure. If we end up in the arena of provider failure, we tend to know it's coming, and we tend to be working with the provider around managing the transition of those customers to alternatives. We have two different work streams and protocols that are kind of relevant. One of them is our care quality and care governance framework, where we work very proactively with all providers in the borough, whether they're domiciliary care, supported living, residential nursing homes. And we work hard with them to drive the quality of the services they're able to provide, which in turn, I would like to think, and I believe, makes them more viable businesses. The more quality you're delivering, the more you attract customers and retain customers. So that all helps with the viability. We then have a provider failure framework, which sits under our strategic commissioning service. So where there are early signs of a provider failure, whatever the reasons for that might be, we're able to bring together a collaborative multi-agency framework around that, work with the provider to see if there are opportunities to prevent the failure, the closure, whatever you want to call it. And if there aren't, then to look at managing that closure and that transition in a way that doesn't put people at risk of harm and ensures they get a continuity of service. You asked in your question about what type of businesses tend to be more effective. I think it's really the domiciliary care market that is the more challenging one at the moment. We've probably had, over the last few years, I think some of our smaller residential care settings have struggled at times. That's not so much the case anymore, because what we had during the first couple of years of the pandemic was a real drop in occupancy levels in care homes for lots of reasons, which of course for those smaller family run businesses or those that weren't part of a big corporation or chain, that created different pressures for them. But I think that's much more stabilised now, with occupancy rates more stable throughout the market, which helps. Does that answer the question?
I think being the budget holder for the Learning Disability Services as well, I can say that we probably are seeing a number of problems in the learning disability market in terms of residential care, which is the costs have escalated and they have become financially unviable for the providers. So I can think of several already in this financial year, residential learning disability places which have shut down because the costs of running those are so high. So that is a pressure on us. Part of our drive in terms of the accommodation projects are because we acknowledge and we understand that there are pressures and we need to drive our own provider locally and our accommodation locally.
Sorry, just come back on both points. You mentioned domiciliary care. That's probably under the biggest pressure. I've actually spoken to some of the companies who run this domiciliary care, and some of them are financial pressures, because what they're saying is what they're getting from the council is not financially viable. The rates are very low. As a result, they have to pay the care workers very low, and obviously it's very difficult to find, especially in the area we live in. So all that chain actually is not working as such, and that's where the pressures are at the moment. So financial viability is because the council is not paying a reasonable amount, which is effective to run a business, right? So, but I suppose I can hear from the council's point of view that you're not getting enough funding from the government to actually, to do that. So, is that fair a reflection? But I've got another question regarding the other point as well.
Sure. I mean, it's difficult for, I think, myself or Lisa to comment specifically on the amount they get paid, because that tends to all go through our strategic commissioning service. So we'd probably need to get more input from them. I think there's also another issue, though, that a lot of providers aren't aware of, and that's a national one, which is, although possibly, I can't speak on behalf of every area. I think some areas may have a shortage in domiciliary care, but we don't have that locally. So actually, there's a lot of capacity in that market, which means that providers who may have staffed up, because there's also employment, recruitment issues, but some will be better staffed than others. They may not be getting the volumes of business that they were anticipating. But that's not because we're not choosing to commission them. It's because there isn't as many hours needed. The reason for that, I think, would be hard to say. We work with a home first policy. So anybody that goes into hospital and is going to require care in the future, very much we work to return them home wherever that is possible. But I think if you listen to the picture that's portrayed in the media, sometimes it's very focused on the shortage of domiciliary care when that isn't our experience locally. But we can certainly get some more information on the rates and come back to you on that.
Thank you. That's reassuring, right? That we don't have an issue locally, but I've heard there are issues in other parts of the country, right? So regarding, just going back to the recruitment of social workers, and you mentioned, I know this is a general problem. It's been going on for a number of years. It's not something new. Can I ask specifically how many vacancies do we have at the moment in the council? And how much is the shortage are we talking about? And what is the attrition rate in this area as well at the moment?
I haven't got those stats right in front of me. Off the top of my head, we're probably running across an adult social care team of about 170. I think it's probably fair to say we've got between 10 and 15 vacancies. So it's not as damaging as it could be. I think we are very fortunate compared to some of our neighbouring local authorities in terms of our recruitment and retention. I think we do reasonably well, but it doesn't take a lot for us to feel the impact of not having those staff there. And I think that we have notoriously had to use agency staff. They cost us, so we're very aware of that, and we are pulling back from use of agency staff wherever we can, because we know that if we continue, we will overspend. We can't do that. We're not able to do that. We've got savings targets, so we are at times running with slightly less than we should have, because we know that the numbers won't stack up. So it's a balancing act.
Phil, next.
Hi, nice to meet you. The famous. I've been warned how good this team are. So I'm sure Ingrid knows, because she's probably one of the people that told me. But I've got a question about the KPI. Talking about the benchmarking for permanent admissions to care homes, and it says that your aim is to reduce the number of long-term admissions. And you say that you're achieving a reduction of people entering care homes. Evidence is we're putting the right measures in place. Now we all recognise that often, and probably most often, it's preferable to be cared for at home than to enter a home, and it's probably more cost effective for the local authority to view people that way. And yet twice I've seen proposals from care home companies, and I'm looking at one right now that tells me that Wokinham's 360 beds short in care homes. Now, if you're looking to keep people looked after at home, is that number going to change? Or are they just doing a sales pitch, which we can't believe? You're not allowed. You don't have to answer that in public. But the point about that is, if they then don't build because it's evidence that the need isn't there, does that then damage perhaps a bit of spare capacity that we have got in that marketplace if they don't build?
I think that the pressure is definitely on in terms of nursing placements and residential dementia, residential nursing as well. We are part of the issues. We are forced to go outside of the borough often, where we don't control some of the quality, we don't control some of the spend. So we do try and keep the numbers down as best we can, and I think we do really, really well at that. But we are struggling, I think it's fair to say, in terms of the capacity in the market for that. The aim is not for us to increase that number. We absolutely want to continue to keep that low. And I think we've done a very good job of that. We've invested a lot of money into our reablement services so that we can get people back up on their feet and allow them to stay at home, which is what most people wish. But we do acknowledge that we do have a met need, and we're paying more because of that, a lot more, and that's part of the issue.
But is it at that sort of level? Are we looking at 360 beds short at the moment? I just don't see that from what I hear from within. You think it's that high?
I personally, I don't think it's that high. I'd like to understand where those figures came from, and we can absolutely give you some information on that. Be really happy to look into that for you. I think the aim would be that we'd like people to come back locally. I think, when we're placing people outside of areas, it's not great for their relatives or carers who've got to travel. So the aim would be that we wouldn't be paying more money. We could bring people back home, those that are in existing placements elsewhere. But we will absolutely check on that stat for you. Happy to do that.
I think the bit that will be fed into that, I mean, whether 360 is an accurate number or not, I couldn't say. But of course, anybody who's looking to develop a care home in the area will be thinking about the self-funding market as well. So we're looking at who we know we have in the pipeline, the demography of the borough in terms of forecasting what demand's going to be year on year. But of course, any business that's looking to set up will also be looking at the whole portion of the population whose parents might presently live 50 miles away, but they want to bring them closer to them. So that will likely be feeding into that number, I would anticipate.
So does that mean that there is actually quite a lot, I gather from what you're saying, there is quite a lot riding on being able to deliver perhaps the Townley specialist dementia care or whatever, however that looks moving forward? Because I guess that's what we're looking forward to meet that need. Yeah,
we absolutely need more capacity in the dementia and the nursing markets. That's without a doubt.
Alison?
Thank you. I wanted to just pick up on this 76% increase in safeguarding that's mentioned in the narrative for AS1 and AS2, because that is huge. And I know there's a reference to some out of scope reference referrals. So I just would like to understand more about how we've got such a huge increase and what you're doing to prevent these out of scope referrals.
Yeah. So the numbers of safeguarding concerns, I can only say they've raised exponentially since pre-pandemic. I think looking at the data for last year in comparison to 2019, we're at more than double the number of concerns coming in. Now, some of that is the out of scope stuff, which I'll just come back to in a moment, if I may. But what I do want to highlight is that the actual safeguarding referrals, so the ones that are in scope, there are more of those, and those that are coming in are generally much more complex when we're getting them. And I think that's because of a whole lot of changes in the landscape, in the vulnerability of people, in the increased isolation and loneliness that happened across the pandemic years, which makes them much more vulnerable to those exploitations and harms that they might be facing. So by the time we get those referrals, sometimes that hidden harm has kind of gained some momentum. So they're a lot more complex and time consuming to work with. In terms of the out of scope stuff, that's been a real challenge. A lot of what we call out of scope are the referrals that come in from the emergency services. And what tends to happen is they label them all as safeguarding, regardless of what the content is. So some of that volume is actually just referrals for adult social care assessment. So things that should really come through the front door. Some of it is concerns around mental health, which needs to go to the common point of entry for mental health services. And sometimes it's just because somebody doesn't really know what else to do with it. But where that's created a problem, or it was creating a problem, was because it was all coming into our safeguarding front door, you couldn't see the wood for the trees. The sheer volume of it was creating risk in terms of us getting to those referrals that actually did contain concerns of abuse or neglect that we needed to deal with quite urgently. Now, we are part of a tri-borough safeguarding board. So we are alongside Reading Borough Council and West Berkshire Council under the West of Berkshire Safeguarding Board. We did lots of work with partners in that board with the emergency services to try and change the way those referrals were coming in. For lots of reasons, not least because those emergency services work across huge geographical areas, which involve many different local authorities and different ways of working. We got to a position in the end where we decided to change our own processes internally. And our current process, which is working well, it's been in place since last December, is we actually bring all of those emergency service referrals in through our main front door. They get triaged there, and anything with an indication of abuse or neglect comes straight through to the safeguarding hub, which works much, much better. What we needed was a solution that still meant a skilled worker was triaging it. We needed to avoid anything that took away that sort of analysis of the contents, but that's worked very well. Alongside that, I would say that, again, during the years of the pandemic, when I think everybody's resources were stretched a lot further, you started to see anxious practice and defensive practice, where people started to refer things that really were never safeguarding, but it was kind of, oh, I'm not sure what to do. Oh, I'll put in a referral and just let somebody look at it. So the other thing we've focused on a lot in the last probably around 10 months is doing one-to-one sessions with a lot of our frequent referrers, educating them around why this referral didn't constitute safeguarding. And we've also introduced another pathway for commission services where they can make care quality referrals or safeguarding referrals. So those things are just about actually the quality wasn't great, but it didn't risk harm to an individual. That will come in through a care quality pathway, and it gets managed through that mechanism, which then enables the safeguarding hub to focus on those referrals which are indicative of abuse or neglect. So those improvements need to continue. We're not there yet. There's a lot of ongoing work to do, but I think I would expect the KPIs for the next year to really show the benefits of those changes. Looking at data today for June, you can see that the 48-hour decision measure has already improved quite markedly. So that's really positive.
Thank you. As someone who's involved with safeguarding referrals almost every day in my day job, not here, I might add, in Frimley, I do recognise what you say about particularly mental health services, the regrowth of referrals to mental health services after the suppression during the COVID period means that actually we're uncovering brand new pockets of concern that previously wouldn't have touched our services and had the chance. So I also recognise that my teams across Hampshire, their stat and man trainings in AS 1 and 2 and 3 for some of them, they're told that if you have to ask the question, is it a safeguarding issue, it's probably best to refer. So there is a bit of a conflict there. But to add to that, the measures you were talking about with regard to new pathways or better pathways, are they specifically looking at the SCAS and Thames Valley Police over referrals, or are they more general across health providers?
So the movement from the safeguarding hub to the front door has been specific to Thames Valley Police and SCAS, and it is working. It's working well, and they certainly are comfortable with it. Picking up on your point, it's a really valid one, because what I'm always very conscious of is you would never want to dissuade somebody from raising a concern where they're not sure, which is why it was important to give alternative pathways as options, which still enabled us to have robust oversight, because you don't want a paramedic who maybe only comes across a safeguarding once every 3 months. You don't want them to feel like they can't raise a concern. If they know something's wrong, then they need to be able to refer it on. And what I always used to say to the board was, it might not be safeguarding, but it's something. They're not raising an issue for the sake of it. There's something not right. So get it into adult social care and let us take the view on it, but let us streamline it so we get it to the right place as quickly as possible in the most proportionate way, so we don't take specialist resource away from something that should be sort of triaged through our front door.
I'm really pleased to hear that the new surveyor system is working, because safeguarding obviously is a very serious issue, and you can't which means action needs to be taken. What is the deadline in terms of within the timelines that the situation has to be looked and as be actioned, and say whether it is a safeguarding issue or is it 24 hours or 48 hours?
Sure. So nationally, unlike child protection, nationally there are no set timescales no statutory timescales for adult safeguarding. But what we work to in the west of Berkshire is we say that all safeguarding concerns, we aim to apply a decision to them within 48 hours. Now, in Wokingham, I went a step further than that, and I introduced a BRAG rating, so black, red, amber, green. Because we have, unlike some of the other authorities, we have an adult safeguarding hub, which is our single point of access for safeguarding referrals. Within, I can never say immediate, because of course workers are always juggling several things, but I can comfortably say within an hour of a safeguarding referral landing in that box, it is scanned, it's looked at, somebody skim reads it, they brag it. So a black rating is somebody's at immediate risk of harm. It needs to be responded to within 2 hours, and it needs to be escalated to the head of service for awareness. Red, amber, green then has a gradated response between the 2 and 48 hours, which gives us more assurance internally. As part of our quality assurance framework for safeguarding, we also periodically audit those things. So we know from our KPIs what our response times are, but we also do some qualitative auditing, for example, around the BRAG rating, to look at whether those professional judgments are correct or a bit nuanced or way off the mark, in order that we can then do the work with those individual staff around that.
Can I add one thing? Just on a similar vein, in terms of the 28-day assessments, just for reassurance, again, those people are not just left on a list for 28 days. There is a RAG rating applied to that as well, so that we can look at the situation, review the level of risk. So it's not like someone's just sat there waiting. We will make sure that, ensure that the situation hasn't changed, so that we can go out and respond in accordance to the urgency. That was worth mentioning.
I don't want to ask a question, actually. I just want to say that having read this, and from the regular updates that I've had, and I've already mentioned your reputation that precedes you, please take back to your teams that there has definitely been improvement, and that what we see is some things that are moving in the right direction and getting things right for our residents. Because I know that when I started campaigning to be a councillor many years ago, that the level of comments that I was getting about adult services were much more severe and more regular than they are now. I just hope, and I've got everything crossed for you, because I know that the team is so strong and so good, that when CQC does come along, that they will recognise those improvements, because I think that it's been a journey, but you're definitely working in the right direction. So thank you.
Thank you, and we appreciate that. We will feed that back to the team, because that's why they're all here, is to make a difference. So to hear that is noticed is really positive and appreciated.
Wow, we're ending almost on a very big positive, which is fantastic. But I have a few minor points. The first one is, I didn't understand this red to green rating. If it's red in Q4, how can it be green at year end? Perhaps you could explain that for me.
So it basically goes across the year, and they look at the average percentage across the quartiles, and then they average it out.
So 3 greens and a red averages a green.
That's a lot more colour of the green, isn't it, than we were expecting? Which one are you responding to, Chair?
Sorry, this is AS2 on page 15.
Thank you.
Yeah, so what that's saying is that in Q4 alone, it became red. But when you look at it across the whole year, the performance in the other 3 quarters was so high that across the whole period, it exceeds the target.
Sorry, thank you very much for that clarification. There was last time, well, a couple of times ago, Wes was here, and I said, I'm going to keep asking this question because it's around workforce and retention and recruitment. So there was a big piece of work sponsored by Sadiq Khan, Mayor of London, which was to look at workforce and poverty and various other things. And one of the key findings was, in comparison to other European countries, we are really, really poor at supported childcare. Okay, so the report said that in Sweden, the average cost of childcare is about £1,500 per year. In London, it's £1,500 per month. This precludes many ladies, especially, it's normally ladies are the primary caregiver to younger children, especially. So I'm going to talk about ladies, but it could be males, it could be whatever. You know, the sex is irrelevant here. The caregiver cannot return to work and sometimes has to leave work because of the caring responsibilities. And the question that I asked Wes was, is childcare going to be part of WBC's workforce plan? And I said to him that I will continue to ask that question to everybody I see, from Susan and the political leaders, you know, Stephen or whoever, because I think this is the key to unlocking staffing. You know, if a person can go to a job and not worry about the care for their child, then they can do that job. If they're looking at an hourly rate and saying, well, that hourly rate means that, you know, I would have to work, you know, X hours to cover Y hours of childcare, which I can't afford, then I can't take that job. So I'm very, very interested in this agenda, because what I want to see is, I want to, you know, Bill's mentioned the team being a very strong team, and that's fantastic. But I want to see the team fully staffed, because I don't want to see agency workers, with all due respect to agency workers. And so, I don't expect an answer to this, but I would like you to talk to people internally and say, what are we doing about childcare? Can we unlock this as a topic so that we can get staffing up to 100%? Another almost secondary topic, and I mentioned this topic to you just beforehand, was that the residents of Evandens and surrounding areas are surrounded by beautiful fields and countryside at the moment, which has never been part of the local plan. There is a new planning application after many applications for building houses, which started at 120, I think, and has moved up to 350 houses on the land between Evandens and Barkham, which the planning team don't like, because this is supposed to be countryside. It's supposed to be the boundary between these two conurbations. It also got badgers and all sorts of biodiversity, which, you know, we regard as critical. It already also has a piece of ancient woodland which is fully TPO'd, which the builders want to put a road right through the middle of the TPO'd ancient woodland. But there is a new building application 231351 for a care home which is partially on existing buildings, but also what looks like paddock at the moment, which is, green field as far as I'm concerned. So I would like you to take that away, and after our discussion earlier on, it might be relevant to get somebody else from your team to present the current building plans for care homes across the borough to this committee, so that this committee is aware of what's in the pipeline.
Thank you. Yeah, we'll take that back to our strategic commissioning team. I think they'd be really happy to come here and be able to talk about any planning applications and the impact upon Wokingham. So we'd be very, very happy to take that back. Did you want me to go on to the point about the supported childcare as well?
I mean, I wasn't really expecting an answer, but I think it's a way forward. I mean, let me be straightforward. I want us to be a really, really good employer, and if we take care of the person, we need to think about the important other people in that person's family. So if they have caring responsibilities, I would like. Well, I come from a German company. We have a subsidised childcare facilities, which make a huge difference to our staff, and enables especially, as I said earlier, our primary caregivers, typically the ladies that work for SAP, to rejoin work earlier or to continue working for us and to not resign. So we don't lose key people because they can drop them off at the subsidised facility.
Yeah, absolutely hear you. Being a mum of three, I hear you. And I think we will take that back to our HR department. I just want to reassure you as something that we do in adult social care, we do rely on a women workforce. We know that predominantly ladies work for us, and we know that predominantly, if not exclusively, falls to women. And we do have a very good sort of flexible working policy for mothers in terms of allowing people to work flexibly at the hours during the week, so it isn't a predominant 9 to 5 all the time, to allow them to pick up their children or whatever they need to do, because we rely on our workforce being responsive flexibly. So that's what we're doing to try and help them now, but we'll take that forward. No worries.
Just to say, Chair, that I completely support. Chair, that I do support. Yeah, and in planning, there's a care home. A developer is in preliminary discussions about it in my own ward, and when questioned, as he said, we need more local beds and it would free up the housing market. And I said, well, a lot of people come from out of our borough into care homes. And he told me that, oh, no, it's an 8-mile radius. So he's going to come back with more information about that. But I just wondered what you thought about that.
I don't quite understand what when you refer to an 8-mile radius, saying that people that come from out of borough only come from 8 miles away, or that we only place within 8 miles?
No, I raised the point that I know a lot of people come from out of our borough into care homes, and I was offered the assurance that, oh, no, we find with our care homes it's only people within an 8-mile radius of the new home who are taking up the beds.
No, so I mean, again, it's that thing about a private marketplace. We may buy block beds in a care home, or we may have first dibs on some beds, as it were, but they can sell their beds to anybody they want to. And you do get people move from all over the country. Wokingham is known to be a great place to live. So it attracts people in that respect, and we'll never change that, I don't think. But our priority is about making sure that we also have the right availability in the marketplace for that end of the market that we know is problematic, which is our people that need the dementia care and the nursing care. Yeah,
because I understand we've got growing numbers of people over 90. and these are people who are going to need nursing care beds, and that's not what developers are wanting to build.
Yeah, that's the other dilemma, isn't it? What's attractive to build, and in terms of viable businesses and all of those other things that come into the mix versus where the need sits may be different things. So,
Shahid, final question.
It's not a question, actually. I'm just thinking based on what you talked about the attrition rates, the policy, etc. It'd be good at some stage to somebody come from the HR side to come and say, look, what is our HR policy? How are we demonstrating that we are the good employer, right? What sort of support are we providing to our social workers as well and the care workers? It's good to, because they are really at the sharp end. And we want to make sure that we provide as an employer the best support they can. And if we do that, naturally, they won't go anywhere. Why would they if they're being looked after, right? I think it'd be good to actually, as a committee, I'm sure other people would like to see that. And certainly I would like to have what we are doing to demonstrate actively that we are actually a good employer, and what practical steps are we taking to make sure that they are being supported. Don't forget, let's not forget, they do a very difficult job, right?
Absolutely.
And it's not
From the committee.
sensible way of taking forward.
Yeah, there's not much point in having a half-baked thing, is there? So, we always want to see the facts based on the factual evidence identified by the investigations. That is, critical. But if you can also come with an action plan, then that is definitely a best case scenario from my perspective.
Great, thank you.
Well, I could quite comfortably sit and put the currently unscheduled topics on an order of priority from my own perspective. I'm sure we all could. Actually, our target should be that we do all of those by the end of the March meeting, if at all possible. I understand, and I guess this might be whilst I'm not sure whilst Ingrid's available. I understand the reasons for the delay in the delivery of the autism strategy, but I'm particularly keen for that to be brought forward. And I realise that that's probably because of a personnel issue. But have we got any indication, and are we going to be able to do something about that sometime soon?
I'll take that back. The individual is back at work, so I'll take that back and get back to you on that.
I'm really looking forward to that. So I'm glad to hear that. So if we can make sure we schedule that, that's my request from me.
Yeah, I think we've been talking about this for nearly 2 years. So, it was when you were chair, right? Yeah, so it's, we want to see else from anybody else.
Yeah, as we're saying that the Health Watch update is not going to be there in September meeting because of just what was said.
Yeah.
So what else is going to be there in the agenda in the place? Now or later on?
Yeah, we'll still have a Health Watch, but not the full report from Woking Medical Centre. That will be deferred. Right. But I think because there will be a shorter briefing from Health Watch, we could maybe add one or two things in. So Madeline will go away with Ingrid and revise this forward programme and then provide an update. Is that okay? Yeah, so you'll get an updated version of this with some of the items included in that September meeting, because the Health Watch briefing, I would have expected a big chunk of that Health Watch update to be around their report on the Woking Medical Centre. So if that's deferred, that gives us quite a chunk of time to add a few items into September. Is that okay with everyone? Yeah, okay. If we discuss the forward programme enough, we'll get a revised draft from Ingrid and Madeline. And I wish everybody a very good evening, and the meeting is closed. Thank you.